Next, you have to see for the face. By the examination of the face, you can again diagnose different respiratory diseases. Say for example, if the patient is breathing in through mouth, okay, that means the patient is in respiratory distress. Okay, that is why he is breathing through mouth. Okay, or he can simply open up the lips and he will be breathing in through those pursed lips. That is called as pursing of the lips. Slight opening of the lips and the patient is breathing through it. Okay, this is pursing of the lips and breathing in through it. In this patient, the nostrils will be dilated. Okay, the dilatation of the nostrils, breathing through the pursed lips, using of the sternocleidomastoid muscles for respiration, then using of intercostal muscles for the respiration. All of this indicates that the patient is in respiratory distress. Okay, the patient is dyspneic. Okay, in such a patient you will note that the respiratory rate is also increased. Okay, so you have to see for any use of accessory muscles, breathing through mouth, dilatation of nostrils, and you have to see for the respiratory rate. If it is increased, then the patient is tachypneic, okay, which again indicates a respiratory disease. And tachypnea is a sign of many diseases, okay, many respiratory diseases like COPD, bronchial asthma, allergies. Okay, so it can be a sign of different respiratory diseases, right? Now, one more thing that you have to note is whether the respiration is symmetrical or asymmetrical. Okay, symmetrical means a phase of inspiration is followed by a phase of expiration, which is followed by again a phase of inspiration and expiration. So if all these phases are synchronous, inspiration followed by expiration, inspiration, expiration, then we call that respiration as symmetrical. Okay, same, the depth of inspiration and the expiration is also equal. Okay, if you found any abnormalities in it, a phase of deep inspiration followed by multiple small expirations, okay, then it is abnormal. That is indication of Cheyne-Stokes breathing. Okay, and which is diagnosis of different metabolic diseases, like in cases of acidosis the patient will have Cheyne-Stokes breathing. Okay, so you have to see for asymmetry of the respiration also. So the respiration must have to be bilaterally equal, it must have to be symmetrical. Then we can call that is a normal respiration. Understood? One more symptom, one more sign that you can notice is tracheal tug. Tracheal tug. What is tracheal tug? When the patient breathes in deeply, the trachea, this portion, it gets inward, it gets what we say is the trachea gets contracted or it gets अंदर की तरफ खींच लेता है. Okay, you will see that depression more prominently. Okay, when the patient is in severe distress, there is tracheal tug. Okay, when the patient is breathing, you can see the depression becoming more prominent over here. Okay, that is tracheal tug. TUG, tracheal tug. Okay, so this patient is not having tracheal tug. His respiratory rate is normal. The respiration is equal on both sides. The respiration is symmetrical. The patient is not having any skeletal deformity. The patient is not having any scar mark. The patient is not having any enlargement of the lymph nodes. Okay, so that we can say that this patient probably is not having any respiratory disease. But still, we have to go for some more signs and symptoms. Okay. Next sign that can be seen is cyanosis, that is bluish discoloration of the skin and mucous membrane. So we are going to see for the palms, we are going to see for the nails, we are going to see for the lips, we are going to see for the sclera, conjunctiva, bilaterally, and we are going to see for the tongue, modu kholo, jib bahar kado, and we are going to see for whether any bluish discoloration is present on the tongues. Okay, so if there is any bluish discoloration, it is cyanosis. If it is present on the face, it is central cyanosis. If it is on the extremities, it is peripheral cyanosis. Cyanosis is also a sign of respiratory diseases. Understood? There is one more sign of respiratory disease that you can see for in a patient is clubbing of the fingers. Okay. Clubbing of fingers is commonly seen in cases of carcinomas, bronchogenic carcinomas. Okay. It can also be seen in cirrhosis of liver, but as far as respiratory diseases is concerned, it is bronchogenic carcinoma. Right? So for clubbing of the fingers, what you have to do is kaka khali M karo, am karo, am. That's it. Okay, and you have to see for that small pear-shaped opening in between the nails that is present. Okay, you can see a beam of light passing through it. That means the clubbing is absent. Understood? So clubbing is absent. That means again the patient is not having any respiratory disease. Understood? So here you have completed the inspection and palpation of the patient in which different signs were absent. Then you can proceed to the next step, which is called as percussion of the chest wall. Basically, percussion of the chest wall is performed in order to rule out any solidification in the lung parenchyma. Okay, lungs are air-filled bags. Okay, it is full of air. So wherever you percuss on the lungs, you will get a resonant sound, because when you percuss, you are displacing the air below your finger. So the sound that will be produced will be resonant. But as soon as that air gets replaced with any solid, consolidation or any fluid, you will get dull note on percussion. So percussion helps you in diagnosis of consolidations and in diagnosis of fluid accumulations, which is called as pleural effusion. It can be hemothorax also. Okay. And suppose if I am getting a resonant note on the right side and I am getting a dull note on the left side of the chest wall, that means the patient is having some disease on the left side of the chest wall. It can be pneumonia, it can be pleural effusion, or it can be hemothorax. And if if the patient is having this disease, then definitely the movements on the left side of the chest will be restricted. The patient will be dyspneic, the patient will be coughing, the patient will be expectorating. Okay, so the symptoms will be there, definitely. Okay. So you have to go for percussion in order to rule out consolidations and pleural effusions. Understood? Once percussion can also be done in order to rule out or in order to differentiate the border of heart from the border of lungs. Okay, but that needs skill, as lungs are air filled and heart is completely filled with blood all the time. When you percuss on the precordium, that is the area of the chest wall just in front of the heart, that is why it is precordium, area of the chest wall which is present just in front of the heart. When you percuss on the precordium, you will get dull note, because the heart, it is always filled with blood. Okay, so say for example this much is the shape of heart. When I percuss on the precordium, I am getting dull note, and as soon as I shift from this heart to the lungs, I will get resonant note, because the lungs are filled with air. Okay, so I can simply tap, go on tapping on the different areas. Wherever I am getting a dull note, that means it is the portion of heart. Okay, where I am getting the resonant note, that is the portion of lungs. Okay, so this percussion also helps in identifying the borders or differentiating the borders of heart from that of lungs. Okay, and by that you can diagnose whether the patient is having cardiomegaly or not. Okay, but this technique is not used anymore. In cases of cardiomegaly, the patient's apex beat gets shifted. Okay, when we will discuss cardiovascular system, in that I will tell you what is apex beat and etc. Okay. So for now, just remember, percussion has two objectives. The first objective is diagnosis of consolidation and pleural effusion, and the second objective is, if you want, you can differentiate between the border of heart and the border of lungs, right? So once you are done with this percussion part, the last and the most important portion of your respiratory examination is auscultation. Okay? So for auscultation, you need a stethoscope. Give me a stethoscope. Okay. So for auscultation, we are going to auscultate the three different lung fields: anterior lung field, posterior lung field, and lateral lung fields. Okay. It is preferable to auscultate on the posterior lung fields. Okay. Because as a beginner, many of the times you cannot differentiate between the heart sounds and respiratory sounds. Okay. On the anterior chest wall, you also listen to the heart sounds. Okay. And it becomes difficult for a beginner how to differentiate between heart and lung sounds. So for a beginner, prefer the posterior lung field and then proceed to the lateral lung field. Okay. So here, the way in which you move your stethoscope, it is very important. Okay. Because we are going to auscultate the lung field in order to do multiple things. We want to know whether the air is entering inside the chest wall or not. Say for example, a patient having obstruction in the trachea, okay, or larynx, there will be complete absence of entry of air on the both sides, right? What we are going to see for is, we are going to see for whether the air is entering on both sides of the lungs or not. Okay, so that is our first objective. Second objective, equal amount of air is getting entered on both the sides or not. Okay. The third objective is, are we listening to any abnormal respiratory sounds apart from normal respiratory sounds? Okay. So air entering into the tubes, okay, like bronchus, trachea, bronchus, major bronchus, minor bronchioles, etc. When the air enters into these tubes, the turbulent sound is produced, okay, because of that passage of the air. But as soon as this tube gets blocked, okay, you get additional respiratory sounds. Okay. So normally, only you can see the entry of air and exit of the air in normal healthy individuals. Okay. But apart from that, if any other sound is getting auscultated, then it is abnormal respiratory sound or additional respiratory sound. So the third objective is identifying any additional respiratory sounds. Okay. So we have multiple objectives. The first one was, is the air entering? Is equal amount of air entering on both the sides? And are any additional respiratory sounds present? Okay. And we have to compare, then the fourth objective is, we have to compare it on both sides. If the additional respiratory sound is present on right side and present on left side as well, or if the additional respiratory sound is present only on the right side and absent on the left side. So it helps you to diagnose that particular disease, whether the sound is on the right side only, so that means the patient is having disease related to the right side of the lungs. Okay. So we have multiple objectives for auscultation. So that is why when you are auscultating, you must have to keep your diaphragm of the stethoscope on any side that you want, prefer right side, upper lobe, and then compare on the left side, upper lobe. Okay. And you have to see for all those things, entry of the air, whether it is present on both sides, then you have to see for how much air is getting entered, okay, and whether any additional sound is present on these lobes. If they are absent on both the lobes, well and good. So you have finished the examination of upper lobe. Then you can simply go to the next portion. Okay. Now you are auscultating on left side, or maybe you can go to the right side. Again, auscultate over here, see for these three things again, then move to the left side, again see for these three things. Okay. If not present, well and good. Then proceed to the lower lobe, right side, lower lobe, left side, and compare. So if you see, this is called as Z pattern of auscultation. Okay, this will be the Z pattern of auscultation.